Kitab Al-Fatihah.
Okay, Bismillahirrahmanirrahim. So I will start today case presentation.
Okay, wait.
Okay.
Wait. Stop. back. Okay. Before we begin, last time when we had this session, it's not with your group, isn't it? Group lain
Ada pernah ada sebelum ni satu session.
Satu session. Okay. Alright. So this session again, it will be the same way, It will be the same way. So again, what do I want from everyone? You know already, kan? So after this presentation sampai summary, and then from everyone, what I want is what is your provisional diagnosis, what are your differential diagnosis, and comment on the presentation. Okay. All right. Okay, proceed.
Okay, so Inshira, a 7-year-old Malay girl, was admitted to pediatric department of HTA due to lower limb weakness for 2 weeks duration. So this case was flagged on day 2 of admission. So for the lower limb weakness, she is apparently well before 2 weeks ago when then she started to feel numbness on the bilateral leg, which eventually led her to have an inability to move both of her legs. The duration between the numbness until the total duration of having the inability to move the legs is about 2 hours. It is occurred before she performing Maghrib prayer, and the site of the paralysis is from umbilicus to bilateral toes, and it is associated with inability to sense voiding and defecation. There is also loss of sensation at the affected area, and there is no involvement of her upper limb, whereby she able to comb her hair, to eat and to read. Okay, so for otherwise, she denied any history of suggestive of some family history with some problem, and it is not preceded with fever, URTI, or gastrointestinal symptom, and there was no trauma prior to the incident, and there is no history suggestive of paraspinal infection of inflammation, as there was no fever and there is no back pain, and also there is no history suggestive of spinal tuberculosis, whereby she does not experience loss of appetite, loss of weight, no night sweat, no back pain, and no history of TB contact. And also she has no non-medical illness that lead her to having an immunocompromised death. And there is also no history, not enough history suggestive of Guillain-Barré, where there is no involvement of upper limb, and no history enough to say to suggest a stroke, whereby there is no altered mental status, no seizure, slurred speech, and facial asymmetry, and there is no history suggestive of space occupying lesion, whereby she does not experience headache, blurry of vision, vomiting, and behavioral changes prior to the illness and during the course of illness. And there is no history suggestive of disc herniation, whereby she denied having back pain and there is no radicular pain. For the progression of illness, on day 3 of illness, as the symptom is not improving, so they seek treatment at HTAA, whereby she is admitted and MRI was done. During the admission, she developed a generalized abdominal pain, whereby it is gradual in onset. However, she does not able to give the pain score, and also, but however, she is still able to socialize with others. And according to her mother, the doctor said it is due to constipation. So she was given enema and the pain relief after passing the stool. So during the admission, she has received 12 doses of prednisolone. However, there is no improvement. So she was transferred to HKL on the end of illness, and she was trained for 6 cycles of plasmapheresis, whereby she only undergo 3 cycles only because post treatment she had hypotension and restlessness, and she developed fever with 38 degrees Celsius with non-itchy macular papillary and on the trunk. And however, it is relieved of pain medication. And during the admission at HKL, she received completed 15 IV methylprednisolone. However, she still have no improvement on her symptom. And according to her mother, the ped neurologist at HKL had mentioned that she had axonal motor neuropathy and was planned for IV immunoglobulin for 5 days. So she was started at HKL and was transferred to HTA to continue the IV immunoglobulin. So upon a systemic review on neurological symptom, apart from the bilateral lower limb weakness, loss of sensation, loss of sense of voiding and liquefaction, there is no other neurological symptom, and other symptoms are unremarkable. So for past medical history and allergic history, she has a non-medical illness before, except that she had eczema during 4 months old and resolved. She had never undergone any surgery, and this is her first hospitalization. And she has no history of food allergy, but that she had recently discovered that she had allergic reaction towards the plasmapheresis treatment. On birth history, antenatally, there is an invalid. During intrapartum, she was born via spontaneous vertex delivery at term with birth weight of 3.8 kg. And postnatally, there is no complication except that this patient had neonatal jaundice and admitted SCN for 4 days and undergo phototherapy and resolved later. For immunization history, she has been vaccinated according to the immunization schedule and completed her vaccination and no complication post-vaccination. She is growing well and developmental is normal according to her age. As she is currently standard 1 at SK Balo, and her mother mentioned that she is cheerful and excellent student. For nutritional history, she eat adult diet, normal adult diet such as rice, chicken, fish, and food. However, she eat less vegetable, and she eat approximately 3 times per day and drink 500 ml plain water per day. For family history, she is the eldest out of 2 siblings, whereby her father is 38 years old, worked as postman, and her mother is 37 years old, which worked as executive assistant. And apart from that, all family members are healthy, no familial history of malignancy or autoimmune diseases. For social history, they live at Pelindung Berserap in a terrace house, whereby their household income is approximately 3,000 per month. The nearest clinic is at Polyclinic Berserap. So upon physical examination, the patient is alert and conscious and lying on the bed while watching video. There is a femoral catheter on her right leg with no swelling or erythematous, no sign of dehydration such as no sunken eye, lips is not dry, the skin turgor is also good, and it is noted there is a CBD on her right side with a clear urine. Otherwise, there is no muscle wasting and the patient is not aggressive. So on anthropometric measurement, she is an underweight female girl. On vital sign, she is normotensive. The pulse rate is normal, and she is febrile and with SpO2 98% under room A. So on neurological examination, on mental status, she is conscious and alert, no slurred speech, cranial nerve is intact. There was no nystagmus, no ptosis, normal pupillary reflex, and there is no facial asymmetry noted. And examination of the spine at the back, there is no deformity and tenderness noted. And the anal sphincter was lax. So upon examination of the lower limb, for both upper and lower limb. So the site is confined at the lower limb where it is symmetrical. For the power is 0 out of 5. The tone is hypotonia with the absent reflex and Babinski sign equivocal. There is absence of tonus and sensation is up to T10. And there is not intact proprioception for lower limb. So for upper limb is all normal. So on other system examination, all are unremarkable. For abdominal and cardio is normal. So for summary, this is a case of Inshira, 7 years old male girl, presented with sudden and rapid onset of bilateral lower limb weakness and loss of sensation with urinary and bowel incontinence for 2 weeks duration, which preceded with numbness at affected area. So on physical examination, is a bilateral symmetrical paralysis of lower limb with absent reflex, sensation up to T10, and loss of proprioception and anal sphincter was lax.
Okay. Wait, stop sharing. Okay, let's see. Presenter dia siapa? Siti siapa presenter dia?
Siti satu.
Okay, alright. So let's get berapa orang semua ni. So okay, from my screen here, the first one will be Syahirah Kamal, and then Nurul Fatihah, and then Nur Zakira, and then Farahiza, Hassan Nasri, Nur Hazikah, Zain, then Shah Al-Hadi, Anis Arisha, and then Nur Alia Azhari. Okay, alright. Proceed. Syahirah.
Okay, okay. So kalau provisional diagnosis, susah sikit lah. So, most probably sebab kes ni dia affect sensory also sebab dia ada loss of anal sphincter. So I would think of transverse myelitis firstly. And then my differential could be Guillain-Barré syndrome, tapi Guillain-Barré dia usually Guillain-Barré satu lagi. And then the next one yang I think we need to rule out is polio. Tapi polio usually asymmetrical. But in this case it's symmetrical dan patient also had vaccination. Other than that, I think we could rule out space occupying lesion.
Apa lagi?
And then spinal cord involvement.
Okay, fine. Comment.
Truthfully, I think she had a good presentation sebab dia cerita explain very thoroughly dia punya flow of the story. Macam I think it is a bit complex for history tapi sebab reasonable sebab case ni macam susah sikit. Tapi kalau nak komen yang lain, dekat physical examination, she said that abdo, respi, macam tu unremarkable. But what is unremarkable? Apa finding dia?
Penat aku bebel lah itu kan. Baru je bila kita buat kelas kan. Ada tak did I membebel to you guys baru-baru ni? Kan? I did say medical students don't do shortcuts. Shortcuts are for consultants. So don't do shortcuts. Do you know why cases like this you shouldn't do shortcuts? Okay, I'll go a bit later. Why you need to go in detail, even the other system as well. Okay, fine. Next, Nurul Fatihah.
Yes. So for the comment.
Yeah, comment. Dulu.
Okay. So my provision is same as Shahira because of the treatment given also suggestive for transverse myelitis because of plasmapheresis and then she was given immunoglobulin. So that is my profession is transverse myelitis. For differential diagnosis is first one is Guillain-Barré syndrome, but the weakness for Guillain-Barré usually from distal to proximal, but this one okay. And then space or cooperation, but the points against such as there is no history of nausea and also vomiting.
Okay. What?
How about spinal TB, but it's less likely. That's all. So for comment, Isato's presentation is quite good, and yeah, you should add some important points. Yes, for example, as respiratory, if we don't know if maybe patients having TB, so we have to check for respiratory system. You did check, but I want to know what is the finding.
Okay. Fine. Next, Nur Zakira.
Okay, can you hear me? Okay, so for provisional diagnosis, I think it is acute transverse myelitis because it has a numbness on the both bilateral leg, and then there is a loss of lower limb motor function, and the sphincter also affected, and the sensory also affected with the absence of the reflex. But once again, she had no urinary retention. For the differential diagnosis, I think first it could be Guillain-Barré syndrome because it affect the reflex and with the symmetrical weakness of the lower limb, and the weakness also started from the periphery, which is from the leg. But once again, I think because there is no recent history of viral infection or any diarrhea, and the loss of the sensory, it is not in the glove and stocking character. And then no pain and hyperesthesia at the lower limb. And then other than that, it could be multiple sclerosis. Because the involvement of the bowel and bladder involvement and sphincter involvement, but other than that, she not presented with optic neuritis or speech slur. That's all. Okay. And then for comment, I would like to know at which day she presented to the hospital. Is it on the day 3 of illness? With that?
Presenter, ya, Mak?
Okay, the patient presented during the day 1 of illness.
Day 1 of illness.
Presented day 1 of illness?
Because the timeline is it on
the weakness is 2 weeks ago, so she presented after 2 weeks.
after 2 weeks.
Huh? Now I'm getting confused. Bila dia present? I thought you said day 3 baru dia seek treatment.
Day 3 of illness.
Terus mana day berapa? Day 1 ke 2 weeks ni? Presenter. Confused aku.
The witness started at 2 weeks ago.
Yeah.
And then at 4 December, and then she was admitted at 19 December.
So okay, bila sebenarnya dia mula-mula seek treatment? Dia admitted dah day 3 of illness. Kan? Ha?
Day 3 of illness.
Day 3 of illness. So the first 3 days tu parents buat apa?
Not sure.
Isn't that important? So dia start jadi witness tu, day. You bagi tahu sebelum maghrib, sebelum sembahyang maghrib, kan? Dia start dengan loss of sensation. Lepas tu jadi weakness, lower limb. Kan? Hari apa? December. Which part of December? Unmute lah, presenter.
During October, 4 October, and then she was admitted during 19 October.
Okay. 4 October, admitted 19 October.
Is during the second admission.
Second admission daripada
Ya,
HKL lah.
daripada HKL.
So you clock ni day 2 of admission from HKL.
After HKL.
So this is one thing that you need to clarify. Because in your presentation, there's one thing that I wanted to comment lah. Your present ni, which day of which admission you're telling me, but it's not clear in your presentation. In your presentation, it's not clear. So when you present, you need to have a clear timeline. The people need to understand. Okay, that's one thing. The second thing, I was planning to comment this later on with semua orang nak comment lah. So one thing is, what did the parents do? Okay, kenapa which day masa onset tu is important? Did the child go to school? October, still time sekolah kan? So dia pergi sekolah tak? 3 days tu before dia came into the hospital. Tak pergi. Pergi ke tak pergi? Kita tak tahu.
I think not, but I didn't
No,
ask.
don't think. If you don't know, don't think. If you don't know, you say you don't know. You tahu ke tak tahu?
I don't know.
Okay. So never think. No, not never think lah. You need to think. Tapi you never say something yang you do not make conclusion. So you need to say what are the facts. Okay. So and then what did the parents do? Isn't it weird? Kalau you lah, suddenly you cannot walk, what will you do? Won't you go and seek treatment immediately? Kan? You will seek treatment immediately kan? Ni takkan tunggu 3 hari kan? And any one of you think you should wait 3 days? Tengok kalau kebetulan Allah punya kuasa tiba jadi sihat baik. Ada ke? No kan? You should seek treatment kan? Isn't it important what happened in the past 3 days? Okay, fine. Next. Siapa tadi? Tadi last sekali siapa tadi?
Saya.
Siapa? Syahira. Syahira. Dia punya susunan ni dah lari dapat dalam ni. Tadi Fatihah dah kan? Farhiza dah ke? Belum? Farhiza. Lepas Farhiza ni Syahira dah kan? Lepas tu Nur Zakira. Lepas tu Hasan Nasri Lepas tu Hazikah. Lepas tu Zain, lepas tu Syah, lepas tu Anis, lepas tu Alia. Okay. Farhiza, proceed. Go.
So the provisional diagnosis will be transmyelitis. Point 4 point 4 because it is a bilateral limb weakness, and it is that it is a paraparesis, betul lah, paraparesis. And then but however and it was said that the point 4 is also loss of sensation and also bowel incontinence, and also there's a presence of numbness. However, point against, there's no history of infection because there's no history of infection, and it was said that okay. So for the differential diagnosis, I will go with Dr. Acute Disseminated Ankle
Adam,
itu diagnosis ke?
Adam is the diagnosis lah.
Oh, okay.
Adam, Pandas, all are diagnosis.
Oh, okay. Okay, I will go with acute disseminated encephalomyelitis because with same reason, because the patient presented with limb weakness and also supported by neurological symptom of numbness, and also there is also bowel incontinence. However, point against, same like Siti already ruled out in her presentation, there is no history of infection or any history of sign of like seizure or vomiting or headache or altered mental status. And then the second one will be Guillain-Barré syndrome. However, point 4 the same. However, point against, it is not, the pattern is not ascending in nature of the limb weakness, and there is
How you know it's not ascending?
sebab kalau what I understand from Siti presentation, she say the site was at, oh ke tak detail.
She
Okay,
didn't say. She didn't say. She only said lower limb. Which part of lower limb?
Because
Where? The whole lower limb tiba-tiba tak boleh move ke ataupun gradual increasing?
okay, so I would like to ask
Suddenly loss of sensation all ke ataupun dia increasing? Ataupun start daripada mana? Start daripada atas dulu ke start daripada bawah dulu? Or sudden or loss? Ataupun worsening, mula just hilang rasa sikit-sikit, lepas tu makin worse. Is it sudden loss of power ke ataupun gradual loss of power? All these are important information. And so as your physical examination. Physical examination pun, this is another issue that I wanted to comment later on lah. Tapi sebab Farah does mention, I'm going to say. You said tadi, you bagi chart tadi, which you won't be able to do in the exam lah kan. You terus bagi, okay, upper limb, lower limb. Upper limb 5/5, lower limb 0/5. Is that adequate? That is definitely not adequate. Kalau you nak present case respi, case pneumonia, case apa, then that's fine lah. Tapi for neurological case, lower limb weakness, obviously you need to go detail. Plantar berapa, so ankle, go according to muscle lah, kan? Kalau upper limb, biceps, triceps, finger, wrist, so go according to at least muscle ataupun joint, kan? Berapa power kat elbow, berapa power dekat shoulder, lower limb, hip power, ankle, knee, kan, toes. You need to go through all those things because some cases they may be different. Sama dengan sensation, you need to go through all reflexes. Tak boleh upper limb, lower limb, tak boleh. That is not enough because your case is a neurological case. Your neurological case, you need to go detail lah. Then you need to go to detail. Okay, alright. Fariza, semua dah? Habis dah?
last will be trauma.
Apa?
But trauma. Tapi sorry, the trauma is not a diagnosis. Okay. Last will be I will stroke, acute stroke or in child. But however, the point four is it will be the limb weakness, but the pattern is not usually stroke is asymmetry in pattern. Comment
Usually stroke is? Usually
asymmetry.
stroke is? What
Sorry,
is?
doctor?
Usually stroke is asymmetry. Okay, fine. Okay, alright.
Yes. Okay. So comment. Generally, it was okay, but however, I would like to know more on the pattern of the weakness. Understand whether it's standing or which, whether it really apa memang dua-dua terus limb weakness for the patient, and also the history of. I think you can elaborate more on the history of infection. You do rule out there is no paraspinal infection, but I think we can also rule out other infection such as whether the patient has yalah URTI or UTI, or basically you already rule out TB, and but we can also rule out macam mana if there any infection like herpes ke. Okay, and also the non-remarkable kan ada systemic. I think it's important we need to rule out any complication of respiratory because usually transverse myelitis patient also presented with respiratory and also cardiovascular complication. I think that's all for me. Thank you.
Okay, comment. Comment habis dah. Okay, fine. Next will be Syahira dah Syahira. Tu belum lagi kan? Syahira dah. Nur Zakira. Nur
Dah, dah,
Zakira, Hassan, lepas tu Hazika.
Doktor dah.
Dah eh? Allah, minta maaf lah. I should have kept name. Hassan. Hassan, lepas tu Nur Hazika. Lepas tu Zain.
Okay, boleh dengar ke?
Boleh.
Okay. First, provisional diagnosis. Provisional diagnosis based on history to lower limb weakness, acute onset dengan ada loss of loss of bowel continence, probably and both bilateral onset, probably transverse acute transverse myelitis, because there is acute muscle weakness. For points 4 is ada bowel involvement, ada weakness starting with numbness, and also it is bilateral. Okay. For points against provisional diagnosis, points against sekejap. Dia ada soalnya points there is transverse myelitis, dia ada preceding factors. However, some cases dia ada idiopathic so no fever, no any infections or viral infections, and that is for provisional diagnosis. For differential diagnosis is Guillain-Barré syndrome. This points 4 is rapid onset, is bilateral, and there is areflexia, and however it doesn't points against is no the presenter did not no prior infection. The presenter did not mention whether there is ascending weakness or any tingling sensation of the limbs, and there is involvement of the bowel involvement of anus sphincter. Okay, for next is uh, uh, I would like to say poliomyelitis. However, there is no signs of infection, and polio is in uh, most mostly to apa under investigation. And the patient also have mentioned there is vaccinated already, so less likely. Next is uh,
Okay lah, Hassan, fine.
okay.
Comment.
Comment. Tadi presentationnya cakap apa flow-nya timeline ada macam flow tu smooth tapi ada macam skip certain parts macam day 1 to day 3 tu macam mana di sekolah semua tu tapi tak ada mention dah tu tadi. Apa lagi? Involvement macam involvement in activities doesn't apa presenter mention about the condition before but condition during tu macam mana dia sekolah tapi
Okay, fine.
okay.
Okay, let's go with the next. Siapa next? Hazika.
For provisional diagnosis, I think this might be transverse myelitis because the patient presented with bilateral sensory deficit and motor deficit, but there's no preceding factors such as infection, and then the differential would be Guillain-Barré because it mentioned that the weakness start from lower limb. However, it does not mention whether it is ascending, and there's no preceding infection history of infection, and there's no back pain. For next is we need to rule out poliomyelitis. However, patient did not have fever and there's no limb pain, and because poliomyelitis usually is asymmetry and patient already received vaccination. And next will be TB spine because it can present with lower limb weakness. However, it is mentioned that there's no history contact with TB patient, no constitutional symptom, and no fever. Next would be spinal cord trauma. Probably because patient come with lower limb weakness. However, there's no patient already mentioned no history of trauma and no back deformity.
Okay. Berapa dah? Okay, comment.
Okay. For comment, I would like to know the detail of the weakness, the distribution, and also the progress because it can determine the etiology of the disease, and also because the I mentioned is polio, so need to ask about bulbar symptom like dysphagia, and also need to ask more on the preceding any important history before the infection, such as fall or infection.
Okay, alright. Next, siapa next? Zain.
Yes, saya.
Yes, proceed.
So, first of all, provisional diagnosis, I think it is transverse myelitis, acute transverse myelitis, because patient have sudden onset of bilateral numbness and lower limb numbness and also bilateral lower limb weakness. And then patient also presented with inability to sense voiding and defecation, and then also have loss of sensation. And then after that, for provisional diagnosis, first of all, I'm thinking of Guillain-Barré syndrome. Um, However, patient does not have preceding infection and also does not have upper limb involvement. And then after that, uh, the next differential diagnosis is spinal tuberculosis. However, patient does not have symptoms of TB such as lo- loss of weight, loss of appetite, night sweats, and then patient also does not have TB contacts and also um, the no symptoms of respiratory tract. And then after that, my differential diagnosis is stroke. However, patient uh, patient's weakness suggestive of patient does not have asymmetry. And then uh, and then my other differential diagnosis is spinal cord injury. However, the presenter clearly said that patient does not have trauma. And then for the comment, I think the presenter have a really good flow, and I really like that for each of the symptoms, the presenter also mentioned that um, uh, what is the present. Okay, let me give you example. So, for example, um, the presenter said for spinal tuberculosis, there is no loss of weight, loss of appetite, night sweats, back pain, no TB contact. So the presenter clearly mentioned that she is ruling out that particular point. So I really like that. And then, however, the presentation have certain plot holes, as doctor mentioned just now.
Okay, fine. Next, Shah. Lepas Shah, Anis Arisha. Lepas tu we are losing Maisarah ni. Maisarah ni presenter itu kan?
Yeah.
Shah, mana Shah? Bangun.
Okay. So okay. So my problem because of this sudden or the onset of lower limb weakness and also with involvement of sensation and also autonomic. So my differential diagnosis is spinal TB. However, this patient does not have any constitutional symptom, does not have any TB contact, which makes it less likely. Otherwise, my other differential diagnosis is Guillain-Barré syndrome. It's already stated that this patient is not preceded by any DI or respiratory infection, and
Is there name tak untuk dia spinal cord TB ni? Ada nama tak? Ada nama tak?
tuberculoma. Okay.
Ada nama tak? Kalau dia involve TB involving the spine.
Sorry, I'm not sure.
Pot disease ke?
Pot spine.
Huh?
Pot spine.
Pot's disease. Pot's disease. So my wife, who graduated in 2007 from IIUM 2006, 5th batch, she got Pot's disease for her final professional exam. Okay, fine. Lagi, Syah, teruskan.
So my other differential should be CVA, cerebrovascular attack or stroke, uh, which should be, as you know, there's hemiplegia, which is a diplegia. There is no involvement of the upper limb, and also there is no family history of such problem. No family history of stroke or no non-medical illness. And then I think I will also think about multiple sclerosis as mentioned by previous presenter. However, the sensation is not on the examination. The sensation is not patchy as it should be in multiple sclerosis. And then for my comment on the presentation, I think it's a good presentation. It explained about the progression of this patient. However, we need. I think we need. She need to explain more about the lower limb weakness and also for respiratory complication that might happen in this patient. We should be in the systemic review and also in the physical examination.
Okay. All right. Anis, Arisha. Last kali. If we don't get back my Sarah.
Okay. So, my professional diagnosis is transverse myelitis as the patient have lower limb weakness, paralysis, associated with the loss of the sensation and also numbness, and patient also has a loss of voiding, unable to voiding. Okay. However, the patient does not has the the preceding factor. For example, any upper respiratory infection. Okay. And next, my provisional diagnosis is Guillain-Barré syndrome because the patient has rapid onset of the weakness. It's bilateral and also absence of the reflex. But for the points against, the patient does not has SND weakness because the weakness start from the umbilicus to the tooth. And also it does not have a glove and stocking distribution, which we can more specify to Guillain-Barré syndrome. And also the patient does not has prior of infection, for example, upper respiratory infection, gastrointestinal symptom. Next is Pott's disease because there is a spinal cord involvement, loss of the motor function, absence of the reflex, and loss of the sensation. For the points again, the patient does not have any cautionary symptom, back pain, night sweat, fever, TB contact, and also the patient does not immunocompromised. Okay. Okay. Next is spinal. Okay. Next is stroke, spinal cord stroke, because the patient has lower limb weakness. However, for the point against, the patient does not have upper motor neuron lesion. For example, hyperreflexia, hypertonia, and also from the cranial involvement, this does not have any significant finding. Yeah, and also that the patient does not have any underlying disease, for example, hypertension and diabetes mellitus. Okay. Okay. Next is poliomyelitis because the patient also has lower limb weakness. However, for the points against, the patient has complete the vaccination. The vaccination, and also the patient does not have any upper respiratory tract infection. Okay. Next for my comment, I want to know, does this is the first or recurrent or presentation of the long weakness, because it is weird for her parents um to leave this patient for to allow this patient to 3 days to have long weakness before presented to hospital. And also I want to know, as since the patient uh, is unable to defecate, does the patient have any symptom of the intestinal obstruction? Because I want to know the severity. Okay, so that's all.
Okay, all right. Let's get back to our presenter. Siti Izzatul. Okay, all right. What is your provisional diagnosis and what are your differential diagnosis?
So my provisional diagnosis is acute transverse myelitis as the evidence of spinal cord involvement, the absence of reflex, involvement of sensory and motor, and also it is a rapid onset, rapid progress, and there is a definite sensory level which can be determined, which is at T10. However, there is no precedent factor. So for differential diagnosis, I think of Guillain-Barré syndrome, spinal tuberculosis, paraspinal infection or inflammation, stroke, and also space occupying lesion.
Okay. So how would, okay, before we go, before we go forward, I've mentioned few comments before regarding what happened in the past 2 days. So in your history, you mentioned early on the chart is rather well before. Okay, what we want to know more is what happened in the first 3 days before patient coming into the unit. And then you didn't clearly mention that you clock day 2 of admission, but that is on the second admission. So if I were you, what I wouldn't say, I would actually, because the second admission, the reason for admission is for continuation of treatment. So I would present this like this. Okay, 7 years old Malay girl, currently being readmitted from HKL for continuation of treatment. And then I go back. So this is the second admission. The child was initially well before, and then at the first admission, then you go through by that timeline. So bila orang dengar, orang tahu dah. Okay, so this is a readmission. And not just that, orang boleh tahu terus. This is the readmission from HKL. The patient was being referred to HKL. One thing that you didn't mention is why was the patient referred to HKL? Referred to HKL, referred to which unit? And then you didn't mention about severity. Maknanya respiratory is it stable, conscious level semua macam mana, blood pressure masa tu semua macam mana, what happened masa the first admission, where was the child admitted in HKL, kena masuk ICU ke, kena apa ke. And then, you know, as I said before, what are the 4 objectives of presentation? Nombor 1 apa?
To get the provisional diagnosis.
To get the provisional diagnosis, to focus on the provisional diagnosis, to sell your provisional diagnosis, to basically to target, to sell your provisional diagnosis. Second objective.
To rule out the complication.
To rule out differential diagnosis. So you need at least 5 differential diagnoses, and all the differential diagnoses you need to point out the points for and points against all the 5 differential diagnosis. You don't actually need to say satu ini points for against. What you don't need to actually explicitly say what is the differential diagnosis, but you can macam you buat, that's fine. Listener tu akan senang sikit lah, tak payah nak proses. But again, a good listener should already know what you are trying to rule out. What is the third objective?
Assess complication.
Look for complications of the disease, because all disease has complication. Transverse myelitis has complication. Kan? What are among the complications? Dia ada, you mentioned kan, dia ada loss of sensation of voiding. Kan? Loss of sensation of voiding. Is it going into spinal shock? Spinal shock is an emergency. Is it spinal shock? Did you go through the things to actually rule out this is a spinal shock? Kan? What is the fourth objective? Fourth,
To look complication of the management.
look for complication of treatment, look for complication of management, because everything you do has its own complication, and not doing things has complication as well. The child was given immunoglobulin. You did mention no response to immunoglobulin. Immunoglobulin has complication. What are those complications? Plasmapheresis has complication. You did mention patient develop reaction to plasmapheresis. What type of reaction? What was given to counter that complication? Those things we need to know, kan? So treatment has its own complication. Was the child started on physiotherapy? What was done, and so on and so forth. So all these things you need to go through. Okay, fine. Next, you did mention among your okay, this is the thing I mentioned again. I mentioned before. Medical students do not do shortcuts. I have mentioned clearly, explicitly before. I do not accept medical students saying other systems are unremarkable. I do not accept medical students saying cardiovascular, respiratory, abdominal system are all unremarkable. I do not accept that. There's only two condition. I did mention, kan? There's only two condition where you can say it is normal, it is unremarkable, but you still need to mention, you need to still expand a bit. What are those two conditions? Apa condition dia?
Don't have time.
Yes, the first one is when you don't have time, your presentation is very long. Siti Izzatul, do you know how long you presented? Not even 20 minutes. I think it's around 15 minutes. Timer ada kan dekat Zoom ni. Yeah, it's around 15 minutes. So in exam, if you present like this, you will have 15 more minutes for discussion. And that is a long time. If I have 15 minutes with you, I will ask about physiology. I will ask about anatomy. Do you want us to discuss about anatomy? Of course no. Kan? Of course no. So don't give time for the examiner to ask you about basic things. Kan? So always check your time. Sebab you should know rough estimate berapa lama. Baru you tahu, sebab you kena control the examiner. Plan, control the examiner. You can control the examiner. You can control the examiner to ask you what you want them to ask, and not ask you what you don't want them to ask. You can control them to ask appropriate questions that you prefer them to ask. You can control the duration for them to ask questions. So don't give time for them to ask too many questions that you don't want. Kan? So mestilah nak kena show your flair. Kan? Tapi bila you shortcut kan, you bagi time pada dia orang. You are inviting them. Please drill me. Please ask me questions. Kan? Unless kalau you dah power gila kan, you are inviting them sebab I'm ready, come, give it to me. Lain cerita lah. Kan? But most of the time no lah. Kan? So don't give time to them. Kan? Okay. That's the first. You tak ada masa sebab your presentation is too long. Second situation, bila? Second situation where you can do shortcuts. Bila examiner clearly says, okay, just mention respiratory symptom, just mention neuro system, other system, no, forget. So only two situation where you do shortcuts. If not, if you don't have time pun, you just cakap, okay, respiratory system is normal, no, bagi summary sikit, kan? No chest deformity, breast sound is clear, entry equal, no added sums. Summary. Kan? You tak payah bagi detail. Cardiovascular system is normal. Normal pulse, normal blood pressure, first and second heart sound is heard, no murmur. GI system is normal, abdomen is not distended, no organomegaly present. Macam tu. You never do shortcuts yang normal, lepas tu you forget about it. No. Especially true in your patient. There are several situations, there are several reasons why I say it is not acceptable for you to say everything is normal. The first one, your patient has complaint of abdominal pain. Kan? Dia ada complaint of abdominal pain, even though the abdominal pain has already resolved. But there are complaints of abdominal pain. Kan? Obviously, you need to tell us more about abdominal examination. Kan? Your patient has loss of urinary and bowel control. Obviously, we expect you to do abdominal examination because loss of them will cause so many issues. Kan? Risk of UTI, risk of so many other problems. So we would expect you to tell us. Because when you say this, bila you kata abdominal system normal, you tak expand it tells us you don't know the complication. You forget that the child has abdominal pain. Kan? Your provisional diagnosis among your differential is stroke. Kan? CVA. Can you tell me one cardiovascular, there's many cardiovascular problem that can cause stroke. Can you tell me one cardiovascular problem that can cause stroke? Siti Izal tak dengar tadi. What?
Atrial fibrillation. Atrial fibrillation.
Yes, atrial fibrillation and arrhythmias. So arrhythmias, cardiac arrhythmias is a risk factor for cardiovascular events. Kan? Lagi? Apa lagi? Lagi? Apa lagi? Cardiovascular causes for stroke.
Coronary artery disease.
Congenital heart disease.
Okay, what type of congenital heart disease?
Valvular heart disease.
What type of valvular? Okay, valvular heart disease. Okay, fine. Valvular heart disease dia boleh ada. Okay, valvular heart disease. Lepas tu apa lagi? Infective endocarditis. Kan? Dia boleh spread. Lagi, common in elderly.
Coronary artery disease.
There is one cardiovascular problem, congenital cardiovascular problem that is mild, that is considered as normal. We don't do anything for it. Tapi it is known to cause TIA, transient ischemic attack, in adulthood. This is the only reason why this problem, masa adulthood, umur 60-70, baru kita buat closure of that problem. Anyone knows?
PDA?
PFO.
Oh.
Patent foramen ovale, or ASD, is a known cause to cause TIA, transient ischemic attacks. It's known. This is the only reason why we close PFO in elderly. Dah tua-tua dah. When I did my training in USM dulu, we did PFO closure for patient umur 60-70 because it's a risk for TIA. PFO in children in your age, in our age, is considered as normal. We don't do anything. Kan? Tapi for elderly, it is a known cause for TIA and stroke. So that's the reason why we do sometimes. So kena expand tak cardiovascular examination? Kena expand kan? Obviously kena expand. Kan? That is why tak boleh, tak cukup kata semua ada sistem sah normal. Sebab banyak sistem yang boleh cause other problems as well. Kan? Even, okay, physical examination, I've said before, neurological assessment tu tak cukup tu. Kan? You need to mention about cranial nerve. You need to go detail, power dekat each ni, reflexes dekat each joint. Kan? Sensation, kena go to each ni, cerebellar assessment, lower limb punya cerebellar assessment macam mana. So kena go through those. Okay, alright, fine. Siti Izzatul, tak Siti Izzatul, kita tanya orang lain lah. Siapa kita nak tanya Kita tanya uh, siapa kita nak tanya? Fatihah. Fatihah.
Yeah.
How if you were the doctor on the first admission in ED, how would you manage this patient?
First, we have to resuscitate this patient as usual. Check for the airway, patency, make sure the breathing is enough. And the circulation, check for blood pressure, and then take proper history because we want to know the cause of this presentation, because it may suggest
Itu je.
orang lain boleh tolong.
Okay, fine. Siapa? You bagi nama seorang. Siapa?
Zain. Zain budak bijak. Zain, help me.
Cepat Zain.
I'm not sure lah.
Sudah. Okeylah. Patah balik pada presenter. Sana presenter. If you were the doctor in ED on the day of first admission, how would you manage this patient?
Okay, first take for history and physical examination, and then for management, for investigation, first do urgent spine MRI to rule out the compressive etiology for decompression as it is emergency, and then do investigation such as blood investigation, take MBC throughout underlying infection, and then take renal profile to check for the hydration status, to check the renal status, and to rule out any electrolyte imbalance, and then do liver function test for assessment of the nutritional status, the liver function for pre-treatment, and then take UPIM to rule out UTI, blood culture and sensitivity to rule out septicemia, and then take stool for poliovirus, as we need to report within 24 hours and send the stool within 2 weeks for the global polio eradication initiative. And then refer to the pediatric neurologist.
Okay, would you do lumbar puncture?
Based on what I read, we need to do the lumbar puncture because we need to confirm that it is a inflammatory causes. But it can be.
Okay, fine. If it is transverse myelitis, what can you find in lumbar puncture? If it is Guillain-Barré, what can you find in lumbar puncture? If it's spinal TB, what can you find in lumbar puncture? I assume you should have read lah kan, sebab 2018 you have 2 years to read.
So for transverse myelitis, there is an increase in white cell count,
Neutrophil, leukocyte, monocyte,
neutrophil increase.
Okay, lagi
And
Guillain-Barré.
then for Guillain-Barré, I'm not sure.
Anyone else?
For Guillain-Barré, we call it cytoalbuminologic dissociation. means that it has increase in protein. However,
Protein
normal
tinggi rabak kan?
however normal glucose and white cell count.
How about Pott's disease? How about spine, TB spine? TB spine, apa dia?
TB spine increase in white cell, predominant is monocyte, and then the glucose is normal.
Okay, fine. Imaging, what type of imaging you want to do? In ED, masa-masa datang tu, you nak buat apa, you punya consultant kata, okay, I offer you to do one imaging. What imaging you want to do?
If one imaging, then I prefer MRI of the spine.
Okay.
So for specifically for transverse myelitis, I would look.
Datang maghrib kan? So lepas maghrib malam, tak boleh buat MRI malam-malam.
The most convenient is spine X-ray.
Spine X-ray, CT brain. Stroke can even be, can still be. So CT brain, I would do CT brain first. Lepas tu buat MRI. Okay. Alright. Fine. I just want to tell you one thing. We do have one patient with spinal stroke last week. Was it last week or 2 weeks ago? I think 2 weeks ago. 2 weeks ago, we have in Susmek a child presented with lower limb weakness, upper limb, and then lower limb weakness. And the diagnosis is spinal stroke. Anterior spinal artery, bukan vertebral artery pun, anterior spinal artery. Presented with lower limb weakness. Just 2 weeks ago. Very, very rare. The patient has PFO. So it's not as rare as you would think. Okay, all right. I think cukup lah. We have it's already 1 hour 15 minutes. Okay lah, tak ada lama-lama sangat, semua pun penat. Okay, all right. Any question?
Doctor, I would like to ask about tick paralysis. Is it occur in Malaysia?
Yes, it's not that common. More in adults. Have you got any information from the academic office? You're supposed to come back for face-to-face bila? Next week
28th.
28th. So in 2 weeks time. Kuantan is now a red zone. So problem. So today, this morning, we've had meeting at the hospital level, Kuantan campus level. And this evening, we have JKMP meeting level. So I think things are not going well for Kuantan. And that affects us as well. So I don't know lah. Pray. I am exhausted being quarantined so many times and being swabbed so many times as well. Okay lah. Alright, fine. I think that's all. Let's end our session with Tasbih Kafarah. So to us. Okay, Assalamualaikum.
Thank you, Doctor.
Thank you, Doctor.
Thank you.